Hey everybody, my name is Dr. Scott Giacomucci. I'm the director and founder of the Phoenix Center for Experiential Trauma Therapy in Media, Pennsylvania, and the author of Trauma-Informed Principles in Group Therapy, Psychodrama, and Organizations, Action Methods for Leadership. And in this video, I want to talk to you a bit about Chapter 11 in this new book. Chapter 11 is titled Trauma-Informed Organizations, From Vicarious Trauma to Vicarious Posttraumatic Growth. So in this chapter and in this video, I'm going to talk a bit about trauma-informed care as an avenue for addressing traumatic countertransference, vicarious trauma, compassion fatigue, and burnout. We'll also talk a bit about the phenomenon of vicarious post-traumatic growth, which I really feel like doesn't get talked about enough. We'll talk a little bit about Sandy Bloom's sanctuary model and creating presence, and some ideas about framing an organization as a complex living system that also can be impacted by trauma and loss in similar ways as individual trauma survivors. And we'll talk about experiential processes from sociometry and psychodrama that can be employed within organizational meetings, within supervision, training sessions to promote vicarious post-traumatic growth and peer support while addressing vicarious trauma. So this is a video on Chapter 11, and there's other videos on the other chapters of the book on this channel that I encourage you to check out if you haven't already. So to begin, I want to talk a bit about vicarious trauma, secondary traumatic stress, compassion fatigue, and burnout. These are all terms that often get used interchangeably, and the difference between the terms is probably less important than the fact that we're talking about them and addressing them. But these are all really work hazards that impact individuals that work in all social service industries. And they can really impact the quality of services that are being provided, the health of workers within an organization, and the success of an organization over time. Vicarious trauma, secondary traumatic stress, compassion fatigue, burnout, they can lead to conflict within organizations. They create additional risks and liabilities within agencies. They disrupt relationships. They impact safety. They decrease staff morale and staff's commitment to the organization. And they impact both the staff and the client's sense of inspiration and hope. So it's really important that we're addressing these in our organizations. And I'd like to argue that organizations actually have an ethical responsibility to consider their staff's well-being. So the term vicarious trauma or vicarious traumatization was originally created with a focus on negative cognitive changes or negative beliefs that professionals might experience as a result of working with trauma survivors. Whereas the term secondary traumatic stress was originally used to describe the professional experiencing traumatic stress secondhand from the folks they were working with. So experiencing classic PTSD symptoms, such as intrusive images or thoughts, avoidance and numbing strategies, and hyperarousal and reactivity. Now, the difference between these two is a lot less important since in 2013, the DSM added negative beliefs and moods as a new symptom cluster to PTSD. So the differentiation between these two terms is probably less important than it used to be, and they often get used interchangeably. Actually, that new DSM definition of PTSD also added a new qualifier that says that anyone who is repeatedly exposed to disturbing details of other people's trauma, even through the course of their work, can qualify for a PTSD diagnosis. This effectively means that anybody working in healthcare, treatment providers, lawyers, can actually meet the criteria for post-traumatic stress disorder solely based on secondary traumatic stress and vicarious trauma that they experience. So these really impact all types of professionals, and they even can impact community members, especially in this day and age of mass media and social media, where disturbing stories and details and images and videos are constantly being shared online. Community members watching and consuming this content can experience secondhand traumatic stress from it. Vicarious trauma is also something that you can experience by being in group therapy. If the therapist isn't thoughtful and careful in containing the group process before establishing safety, and somebody starts telling the gruesome details of their past trauma, hearing those details can vicariously traumatize others in the group. So another term that is often used interchangeably with secondary traumatic stress is the term compassion fatigue. So compassion fatigue is the sense of numbness or indifference, desensitization that we might experience through our work, the loss of morale. Burnout is another term that often gets thrown around in these discussions. Burnout's a little different in that it's a state of exhaustion that we might experience from overworking without proper self-care. And burnout often emerges as a sense of forgetfulness, irritability, anxiety, feeling overwhelmed or depressed or helpless or hopeless in the context of work. So burnout is not specifically trauma-related, but it certainly can be. And many times, vicarious trauma and compassion fatigue and secondary traumatic stress really fuel one's experience of burnout. So there's been a whole bunch of research about burnout and vicarious trauma, secondary traumatic stress, and some of the research is pretty alarming. At least I found it alarming. In one study, they found when they interviewed 250 trauma therapists, over 70% of them were at a high risk for secondary traumatic stress. So that's pretty high risk simply from working as a trauma therapist. Another study found 70% of social workers were reporting at least one symptom of secondary traumatic stress, while 42% of social workers were indicating that they're really suffering from secondary traumatic stress. So those are pretty high numbers, pretty alarming. 34% of child welfare workers in another study actually met criteria for PTSD themselves based entirely on secondary traumatic stress. Another study found that 47.5% of frontline healthcare workers were suffering with secondary traumatic stress during the COVID-19 outbreak in 2020. So that means about half of healthcare workers struggling with secondary traumatic stress. Multiple studies have highlighted that vicarious trauma is a predictor of staff turnover, of people leaving their jobs, and a predictor of negative outcomes for staff, for organizations, and even for clients. So vicarious trauma is really something that we have to address in our organizations. Otherwise, it's going to lead to staff leaving. It's going to lead to negative outcomes. There was a systematic review about burnout within psychotherapists where they had almost 9,000 participants in total, and they found over half were reporting moderate to high levels of burnout. Over half. That's a lot. Another study with 400 psychologists found that just under half were reporting moderate to high levels of burnout. So burnout's pretty high within psychotherapists and psychologists. Various studies have demonstrated burnout to impact the professional's physical and psychological well-being. It impacts sleep. It exacerbates medical issues. It can lead to memory problems, to mental health issues, relationship problems, absences at work and staff turnover, poor work performance, and even misconduct at work. The authors of this study in 2019 commented that the ethical impact of burnout extends to our duty of care to clients and responsibilities to the employer, which I thought was a really fitting and poignant quote. So vicarious trauma and burnout are not just the responsibility of the individual to deal with, but I want to challenge us to consider these as also partially a responsibility of the organization to address, and maybe even partially the responsibility of the systems within we work to also be looking at and addressing. So Sandy Bloom and Farrager in 2013 write that it's becoming increasingly clear that burnout is not a problem of individuals, but of the environments within which people work. A NASW social work study in 2007 found that participants actually experience more stress from their workplace environment and their working conditions than from the vicarious stress of working with trauma survivors. Social workers have more secondary traumatic stress and burnout in organizations where there's a lack of organizational support, a lack of supervision, and limited training in trauma. So all of these research findings are really pointing to the fact that burnout, secondary traumatic stress, vicarious trauma are not just something that professionals experience because of the trauma survivors they're working with and the stories they're hearing, but that they're also experiencing this because of the workplaces, from toxicity within the workplace, from a lack of support, a lack of training, a lack of supervision. And these studies really confirm what I've found to be true in my own experience as an employee in organizations, talking to clients about their workplaces and their work stress, supporting supervisees and trainees in various workplaces, and supervising graduate students. That in all these situations, it seems as though for most of the people that I've spoken to, when I reflect, that the workplace is a higher cause of stress than the clients that an individual is working with. Now, in terms of assessing for burnout, secondary traumatic stress, there's a really useful assessment tool. It's called the Professional Quality of Life Assessment. Many times it's just called the Pro-Qual assessment. It's 30 questions that you can fill out on your own and add up your scores using the instructions provided. And it'll give you a key for interpreting what your scores mean. And it provides you with a rating on what your level of burnout is, your level of secondary traumatic stress, and your level of compassion satisfaction, the amount of satisfaction that you're getting out of helping the people that you serve. So this is an assessment tool that I often fill out for myself to gauge where I'm at personally, professionally. It's an assessment tool that I often give out when I'm providing trainings in organizations, especially trainings on vicarious trauma and burnout. And it's a tool that I encourage all professionals to keep close by and to fill out on a somewhat regular basis. If you fill this out on a bi-weekly or even a monthly basis, it can really give you some insight into where you're at in terms of your professional quality of life. You can track changes in your burnout score, in your sense of secondary traumatic stress, and your satisfaction that you're gaining from the work. And it can help you be more self-aware so you know when you might need to make some changes, when you might need to schedule that vacation, when you might need to ask for more supervision or get more training or seek more peer support or even change jobs if you're not finding the support you need in your current job. So we'll put a link in the description below for this professional quality of life assessment tool. It's been translated into tons of different languages and it's freely accessible online. Now, similar to vicarious trauma, we also have this other phenomenon called traumatic countertransference. So traumatic countertransference is simply when the professional's projecting their own past onto the client, or more specifically, projecting someone from their own past onto the client. Traumatic countertransference, then, is when the countertransference is related to past trauma. That the professional has their own experience of past trauma that's unresolved and that's being activated and projected onto the client. Now, often when the therapist or the professional is experiencing countertransference, it also means that the client might also be experiencing transference, which is where the client is projecting someone from their past onto the therapist. So there's a sort of reciprocal nature to transference and countertransference. And it can be a really tough thing to work with in therapy, although it also can be a source of incredible repair and healing when we learn how to skillfully work with transference and countertransference. And they both are really unavoidable in trauma therapy, completely unavoidable. Some people would even argue that transference and countertransference are always shaping our experience and impacting us in every single relationship that we have, every single therapy session, and even in our relationship with our supervisors, our professors, our trainers, and the leaders of our organizations. Now, traumatic countertransference can be really stressful. It's triggering and activating the past trauma of the professional. And therefore, it can really fuel vicarious trauma, secondary traumatic stress, compassion fatigue, and burnout. It's something that's usually experienced within the relationship with a client, but it also can be experienced elsewhere. And it can be a real source of stress if you're experiencing traumatic countertransference or transference with your supervisor or with the leaders or other colleagues within your organizations. Now, in the research, there was a summary of the research, and they found 5 specific things that organizations can do to reduce the impact of traumatic countertransference, vicarious trauma, and burnout. And these are the 5 different things. Organizations can provide ongoing and consistent supervision for staff, especially for newer and younger clinicians. And newer and younger therapists are at a higher risk for burnout and secondary traumatic stress than more experienced therapists. The second thing, organizations can cultivate peer support for staff within their organizations, opportunities for the coworkers to come together to support each other. The third thing is that organizations can reduce or rotate direct service hours if possible. So to shift the position of staff members so that the same staff member isn't always the one leading the group or isn't always the one doing the crisis interventions or isn't always the one who's managing the crisis calls or the hotline, but that there's some sort of rotation that gives people a break. The fourth thing organizations can do is provide training and education related to trauma for their staff. And the fifth and final thing organizations can do is to empower staff to address their own trauma by encouraging or providing or funding opportunities for counseling and personal growth. So these are 5 things organizations can actively do to support their staff in reducing burnout and vicarious trauma. So I want to pause for a moment and challenge you to consider, how do you navigate your own experience of traumatic countertransference and navigate your own experience of vicarious trauma? If you're a professional working in the field, you're going to experience countertransference and vicarious trauma at some point, if not already. And how are we going to navigate it when we're experiencing it? How will we even be aware of when it's impacting us? Many times these can be things that happen unconsciously, and we might not even be aware that it's happening. How can we create habits or structures within our work life that help prevent burnout for ourselves, for our staff members, and for others in the agency? So these are bigger questions that I encourage everyone to reflect on. I don't necessarily have all the answers to these questions, and the answers and solutions are going to be different from person to person and organization to organization. But I'm hoping some of this video and this chapter can shed some more light and offer some other options to answering these questions. Next, I want to talk about vicarious post-traumatic growth. So vicarious post-traumatic growth in many ways is the opposite of vicarious trauma. It's the phenomenon of growing as a result of working with trauma survivors. So vicarious post-traumatic growth is when the professional experiences their own personal and professional growth from the work that they're doing. So it's similar to post-traumatic growth, which is the phenomenon of growing in the aftermath of trauma. However, it's happening vicariously. Sometimes it gets described as vicarious resilience. So vicarious post-traumatic growth shows up in the same 5 domains as regular post-traumatic growth. It emerges as a new sense of personal strength, a new value in relationships, a new sense of spirituality or commitment to religion, a new sense of opportunity in our life, or a greater appreciation for life. And so these are 5 different areas of post-traumatic growth that professionals can also experience vicariously through work with their clients. In the research on vicarious post-traumatic growth, they actually find that over 70% of people, professionals, report vicarious post-traumatic growth in various forms, including living life more fully, treating others with more kindness, or simply being more emotionally present or expressive in our own personal lives. In the systematic reviews and meta-analyses on vicarious post-traumatic growth, they find that there's 4 things that we can do, that we can actively do to increase our likelihood of experiencing vicarious growth through the work that we're doing. First one is to engage in supervision. Second one is to engage in peer support. Third one is to engage in self-care. The fourth one is to engage in our own personal therapy and personal growth. So these are 4 really concrete things that all of us as professionals can engage in to reduce our vicarious trauma and burnout risks and increase our risk of growing from the work that we do. Now, in these reviews in the research, they found other variables that were related to vicarious post-traumatic growth, which are pretty interesting. So these are variables that lead to more growth for professionals. So these include a sense of satisfaction and compassion satisfaction, competence in one's work, valuing one's own work, humor, empathy and optimism, positive affect and emotions, self-esteem, more time in one's role or occupation, and witnessing traumatic growth in clients. So these are all different variables that can increase our likelihood of experiencing vicarious post-traumatic growth. Interestingly, in the research, they also find that professionals who have a trauma history themselves and are in their own personal therapy tend to report higher rates of vicarious post-traumatic growth, which makes a lot of sense to me. Another study found that therapists that work from a humanistic or transpersonal theoretical orientation are more likely to experience vicarious post-traumatic growth, whereas cognitive behavioral therapists were actually a lot less likely to experience vicarious post-traumatic growth, which I thought was pretty interesting. So this is a field of study that continues to grow, and I find it especially important that we're talking about vicarious post-traumatic growth. It's great that we're starting to talk a lot more about vicarious trauma and burnout, but I actually have never heard a trainer or a professor or an educator or a supervisor talk about vicarious post-traumatic growth. It was a concept that I stumbled upon while I was reading boring research studies about vicarious trauma and about post-traumatic growth in writing this book, actually. And when I found it, I thought, man, we need to be talking about this more. This is such a hopeful phenomenon that we can actively be cultivating in our workplaces. And it really helps to balance out the risks of vicarious trauma if we're cultivating and working towards vicarious resilience or vicarious post-traumatic growth. So ever since I discovered this concept in the research and read about others who are writing about it, I've made it a point to try to talk about this as much as possible and teach about it as much as possible. So at this point, I want to challenge us to pause for a moment and to reflect on what are some of the specific ways as a professional that you've experienced vicarious post-traumatic growth as a result of your work. I know for myself, sometimes the courage I see my clients demonstrate challenges me to be more courageous in my own life. Or the childhood trauma that my clients talk about challenges me to be more grateful for the childhood that I had, or the ways that I experience my clients to make meaning in the aftermath of death and loss really inspires me in my own meaning-making process around the deaths and losses I've experienced. Or when I have a client who has a really conflictual marriage, it challenges me to value and have more gratitude for my marriage, for my relationship. That when my clients are expressing gratitude about little things in life, really challenges me to be grateful for my own life as well. So, what are the ways that you've experienced vicarious post-traumatic growth as a result of your work? I encourage you to put some of those examples in the comments below. Next, I want to talk a bit about SAMHSA's guidance for trauma-informed organizations. So SAMHSA is the Substance Abuse Mental Health Service Administration, which created the original publications on trauma-informed care and trauma-informed organizations. And actually, all their publications are accessible for free on their website. You can download entire books they've written and compiled about trauma-informed care and organizations. And other videos on this channel and other chapters in this book really go through SAMHSA's definition for trauma-informed care in a more comprehensive manner. So if you haven't already looked at those videos, I encourage you to check out those videos as well. So just as a very brief overview, SAMHSA talks about the 4 R's of trauma-informed care as an overview of the philosophy, essentially. First is that we realize trauma has widespread and extensive impacts on individuals and communities, and that there's multiple pathways to recovery. Next, we recognize the symptoms of trauma and traumatic stress, how the past is showing up in the present for the individuals that we're working with, or for ourselves. Third R is that we respond through policies, procedures, and practices. And the fourth R is that we resist re-traumatization in all aspects of our work. So again, trauma-informed care was largely created based on the realization that organizations were unknowingly re-traumatizing the folks that they were trying to help and work with. So we need to be careful and make sure we're not causing any more harm through our organizations. And this means not just causing harm to the clients, community members we're serving, but also that we're not causing harm to the staff that we're employing. So these are the 4 R's of trauma-informed care. Then we have the 6 principles. We have safety, trustworthiness and transparency, peer support, collaboration, mutuality, empowerment, voice and choice, and issues of identity, culture, history, and gender. So these are the 6 principles of trauma-informed care. So trauma-informed organizations look at every aspect of their organization through the lens of these 4 R's and these 6 principles. And SAMHSA went as far as even providing and outlining 10 different agency domains that organizations can look at as they try to implement the 6 principles and the 4 R's in each of these 10 domains. So the 10 domains are 1, governance and leadership, policy, physical environment of the organization, engagement and involvement, cross-sector collaboration, screening, assessment and treatment, training and workforce development, progress monitoring and quality assurance, financing, and number 10 is evaluation. So a trauma-informed organization takes each one of these 10 domains one at a time and critically reflects within that domain on how they're embodying these 6 trauma-informed principles and the 4 R's, and how they can better embody those principles and those 4 R's. So becoming a trauma-informed organization takes work, takes energy, it takes humility. We have to be able to admit that we can be better. And we must involve staff at all levels of the organization in order to help move the organization towards trauma-informed care. So this includes the leaders and board members, the management, the clinical staff, the administrative staff, operational staff, and all frontline staff. So becoming a trauma-informed organization has to be a top-down and a bottom-up process that everybody has to be on board with it. Because it can be so complicated to become a trauma-informed organization or to take and operationalize these 6 principles, these 4 R's into the real world, SAMHSA even created a 10-stage process that organizations can follow when they want to begin or continue their journey towards implementing trauma-informed care in their organization. And so these are the 10 steps. Number 1, first we have to make a commitment to becoming a trauma-informed organization. So it's got to be a real conscious thing that we decide to do collectively as an organization. Second stage, we create some sort of infrastructure to begin, support, and guide the changes. So now that we've made a commitment, we have to create some sort of structure within the organization that's going to allow us to implement change. Then we've got to involve participants from across the organization, clients, staff, and community members. Fourth stage, we assess the current policies in the organization, the current procedures and operations, and determine how much they aid or inhibit trauma-informed approaches. This is where we really have to be honest with ourselves about how we're helping or not being so helpful in implementing trauma-informed care. 5, we create a plan to further implement trauma-informed care in the organization based on the realizations we've had, the new insights we've developed. 6th stage, we develop collaborations with staff, clients, community members, and other service providers from different sectors who can help support us and challenge us to be more trauma-informed. 7th stage is that we have to follow through and actually put this plan into action. It's not enough to just talk about it in a board meeting or to have someone come in and do a short training on trauma-informed care. There has to be follow-through. We have to put these ideas into action. We have to modify our policies, modify our procedures, implement our training. 8th stage, we reassess how the plan was implemented or not, how valid it was, and how relevant it's been. And we have to keep continuously reassessing how are we doing and continuing to grow as a trauma-informed organization. 9th stage is that we use different measures to improve the quality and effectiveness of our approaches to meet the needs of the staff and the communities that we're working with. So essentially, we're implementing some sort of outcomes-based measures and evidence-based care. And number 10, that we implement practices that promote sustainability, including training, education, supervision, peer support, feedback, and the distribution of resources within the organization. So these are the 10 different stages that an organization can actively engage in order to begin or continue their journey to implementing trauma-informed care. In one of the organizations that I've been a part of, what we did was we created a committee that involved the CEO, the clinical director, the medical director, a handful of therapists, supervisors, nurses, and other staff members. And this committee or task force met every week or every other week to talk about different ways of better implementing trauma-informed practices within the organization and trauma therapy within the treatment program. And so we got perspectives from all the different departments, from staff at all different levels. And at the end of each meeting, we made a list of things to do and delegated them to individuals within the committee. And in between meetings, we got stuff done. And there was some accountability for ensuring that when you committed to doing something, that you did what you said you were going to do and implemented it. So we were reassessing what was working, what was getting done, and what wasn't getting done at the beginning of each meeting. What were the action items from the previous meeting? And did we accomplish those? And if not, what were the barriers that got in place? So this is a simple thing that your agency, your organization can do to move through these 10 different stages and work towards becoming a trauma-informed organization. And this is relevant suggestions for any and all organizations. Trauma-informed care is something that any organization in any industry or discipline can benefit from. It's not just something that was created just for therapy or treatment centers or therapists. And every organization, no matter how trauma-informed they are, can always be better. So any organization can benefit from going through this process. So I want to challenge you for a moment to pause and reflect on these 10 stages and consider which of these stages has your organization already engaged in, directly or indirectly, consciously or unconsciously, and which of these stages might your organization benefit from revisiting. To further help organizations implement trauma-informed care, SAMHSA also created 16 strategies that they published in their implementation guide for behavioral health administrators to consider when trying to become a trauma-informed organization. So 16 strategies, and we're going to go through them briefly here. Strategy 1 is to show organizational and administrative commitment to trauma-informed care. Number 2, use trauma-informed principles within strategic planning of the organization. 3, Review and update the vision, mission, and value statements within the organization. These are really concrete things an organization can do. Strategy 4, assign a key staff member to help facilitate change. Make this a part of somebody's job description. Strategy 5, create a trauma-informed oversight committee. This is a committee that's tasked with the oversight or the responsibility of moving the organization towards trauma-informed care. Strategy 6, conduct an organizational self-assessment of trauma-informed services. And there's multiple different ways of doing that. There's some formal assessment tools that can be done and other informal ways of self-assessing. Strategy 7, develop an implementation plan. Strategy 8 is to develop policies and procedures to ensure trauma-informed practices and to prevent re-traumatization. Strategy 9 is to develop a disaster plan in the event of crisis or disaster or some other form of violence or collective trauma within the organization. Strategy 10, incorporate universal routine screenings. So this is about evaluation and screening. Strategy 11, apply culturally responsive principles in our work. Strategy 10, use science-based knowledge. So this comes back to outcomes and evidence-based practice. Strategy 13, create a peer support environment within the organization. Strategy 14, obtain ongoing feedback and evaluations. Number 15, change the environment to increase safety. This would be for not just community members and clients, but also for staff members. And finally, strategy 16, develop trauma-informed collaborations. So we have to really implement all 16 of these strategies within our organizations, in addition to the 10 phases or stages outlined above. And these are basically a toolkit that SAMHSA has created for us to really guide us step by step on how to implement trauma-informed care within our organizations. To take these ideals, these principles, these philosophies, and in a real practical way, bring it into our organizations, into our environments, into our workplaces. So if you wanted to dive more into that, you can actually download SAMHSA's book, Trauma-Informed Care in Behavioral Health Services. It's tip 57. You can get it for free on SAMHSA's website. And pages 161 to 171 go through these 16 strategies in more detail. So I want to challenge you for a moment to pause and reflect on these 16 strategies. Which of these strategies could your own organization benefit from revisiting? Which of these strategies do you feel like your own organization does a good job with? Next, I want to talk a little bit about the sanctuary model and creating presence, both created by Sandy Bloom. So the sanctuary model is a trauma-informed systems approach that was created in the late 1980s in a Philadelphia area psychiatric hospital. Sanctuary model integrates attachment theory with neurobiology of trauma and the importance of community. And it's really influenced by the European version of the therapeutic communities. In the sanctuary model, there's 7 commitments, and these 7 commitments provide a foundation for all interactions between staff, clients, and leadership. First one is about nonviolence. Second one is a commitment to emotional intelligence. Third is a commitment to social learning. Fourth is a commitment to open communication. 5, commitment to democracy, democratic decision making. 6th is a commitment to social responsibility. And 7th is a commitment to growth and to change. So these 7 commitments are really core and foundation for all interactions between staff, clients, leadership, and others within the sanctuary model. The sanctuary model proposes what they call SELF, S-E-L-F, self. Safety, emotions, loss, and future. as a compass for recovery, which is a comprehensive curriculum and foundation for interventions, for group facilitation, for services, community meetings, and even staff meetings. So SELF is almost like 4 stages. You can see it reflects the 3-stage clinical maps outlined in other therapy modalities that can guide us and provide a compass for how we're structuring sessions with clients and staff members. So the sanctuary model has become really popular, at least in the Philadelphia area, and there's been a number of research studies on it. More recently, Dr. Bloom has initiated the next evolution of her work called Creating Presence. Presence being an acronym that articulates the core values of her new philosophy and practice. So the P stands for partnership and power. R, reverence and restoration. E, emotional wisdom and empathy. S, safety and social responsibility. E, embodiment and enactment. N, nature and nurture. C, culture and complexity. E, emergence and evolution. So, presence, this is the philosophy, these are the core values that guide the practice of her new model. Presence was created during COVID-19, during the pandemic, as a self-paced online course to make trauma-informed organizational guidance more accessible. More accessible logistically, more accessible financially. So if you wanted to learn more about sanctuary model or creating presence, I really encourage you to check out Sandy Bloom's work. She's got a number of books and a number of videos and publications online as well. Sandy's ideas have really influenced my thinking about organizations, and she was actually one of my professors in my doctorate program. One of the things I learned from her that really stuck with me was the idea of parallel processes within organizations and thinking about an organization as a living and breathing organism. She writes that organizations are not machines, but are living, complex systems, and as such, are every bit as vulnerable to the impact of trauma and chronic stress as the people who receive and deliver services. So, this means that just as an individual's past trauma and loss can impact their behavior, their emotions, can lead to defense mechanisms, impact their relationship, their well-being, their beliefs, their values, their perspectives, their sense of self, so too does the past trauma and loss of an organization as a whole. Organizations are prone to respond to trauma and threat in similar ways that individuals respond to trauma and threat. However, these organizational responses are collective traumas, and they happen at a group and collective level. Some examples might be different social defense mechanisms, such as denial, or coercion, or avoidance, or scapegoating, that happens at a collective level within an organization. Organizational hyperarousal, everyone feeling like they're walking on eggshells, looking over their shoulder, feeling afraid and feeling like they've lost a sense of safety in the workplace. Ongoing organizational stress, loss of emotional management within the organization, organizational disabilities or amnesia, communication problems, conflict, abuse of power, organizational injustice, helplessness, unresolved grief, or even organizational trauma reenactments. That these are all things individuals experience related to trauma, and also things that organizations can experience in the aftermath of trauma. So I want to pause and challenge you for a moment to reflect on what are the traumas, losses, defenses, or other collective problems that your organization experiences. And if we were to consider our organization in the same way we might consider the case study of an individual trauma survivor, how might the development of our organization, or the structure of our organization, or the behavior, or defenses, or losses, or trauma, or strengths, or growth of our organization help inform us about working with or within the organization? Actually, when I was in Sandy's class in graduate school, the assignment she gave us was to do a case study of an organization and to write about the history of trauma and loss within that organization and reflect on how its history, its development might be impacting it currently, which I thought was, it ended up being a really illuminating and insightful assignment for me to do. So I could encourage you to consider the same for your organizations. The other thing that I wanted to talk about that I learned from Sandy is the presence of parallel processes between staff and clients and between leadership and staff. So there's often a parallel process, a similar kind of mirroring of behavior that's happening between the staff and the clients and the leadership and the staff. That if the leadership and the staff if the leadership is really avoidant or minimizing problems or denying issues with the staff, then there's likely to be a parallel process in that the staff are going to minimize issues, deny, avoid issues with the clients. Or if the leadership's being abusive, then it's more likely that the staff might be abusive, or even the clients might be abusive. If leadership are dehumanizing clients, it's more likely that the staff are going to dehumanize clients and that clients are going to dehumanize themselves. If leadership is defensive, it's more likely that staff are going to be defensive. However, if the leadership is empowering staff, it's more likely that staff are going to feel empowered to empower their clients. If the leadership are demonstrating humility and vulnerability and compassion and understanding, more likely that the staff will be able to demonstrate the same vulnerability and humility and compassion, understanding with clients. So there's often a parallel process that's happening in an organization. And as leaders, as clinicians, as staff members, we can really look for these parallel processes. Sometimes it emerges in the opposite direction, that when there's drama going on within the community of clients, that it might lead to drama or chaos going on within the staff and within the leadership. So this can really go both ways. Regardless, a traumatized organization that's not begun to address its own trauma, dysfunction, loss, secondary traumatic stress, and burnout, and attend to the needs of its staff, is in no condition to be providing trauma-informed services, and especially in no condition to be providing trauma therapy or trauma-focused treatments. So it's really important that we're considering the well-being of the organization as a whole, in addition to the well-being of each person within the organization. Next, I want to talk to you about using sociometry, psychodrama, and sociodrama within organizational settings. So, if you're not familiar with sociometry, psychodrama, sociodrama, I really encourage you to check out some of the other videos on this channel, particularly related to the earlier chapters in the book, or check out some of my other work to familiarize yourself with these processes. I'm not going to really go over what exactly they mean in this video in much detail, so it would be important to go check out those videos, read up about it, and then come back to this video. So, implementing sociometry, psychodrama, and sociodrama within our organizations provides us with an avenue for cultivating peer support, engaging in experiential learning, prompting self-care, increasing organizational cohesion, and providing psychodrama trainings or trainings that are using experiential teaching methods are simply much more engaging than providing a training that's based on lecture or PowerPoint. The provision of psychodrama or experiential trainings within an agency seems to directly or indirectly address each of the 5 recommendations that were outlined earlier in the 2017 study about reducing burnout and secondary traumatic stress. So those 5 areas were supervision, peer support, reducing and rotating direct service hours, providing trauma training and education, and providing avenues for personal growth or counseling. So in some direct or indirect way, each of these 5 areas can be addressed through providing psychodrama trainings within your agency. Psychodrama training is a bit different than other trainings in that it often involves some personal growth and participants doing some of their own personal work within the training through demonstrations. There's ways that in psychodrama sessions and psychodrama warm-ups and sociometry processes, while we're teaching content, we're also challenging individuals to reflect on their work and engage in peer support and peer supervision, or through questions, engage in supervision related to their client interactions. Of course, providing psychodrama training is directly providing training and education. And the very nature of providing a training within your agency means that you're reducing and rotating direct service hours because the individuals are attending the training instead of providing services. So there's lots of secondary good reasons for bringing a psychodrama training to your organization. Historically, psychodrama has been used, sociometry has been used in various organizations, various industries, in government agencies, and all branches of the military. The founder of psychodrama, Jacob Moreno, one of his first jobs after completing his medical degree in Vienna was that he worked as the chief physician of a fabric factory in Austria and was the public health officer of the town. So and this is going back over 100 years ago now. So his ideas about well-being and mental health and group dynamics were implemented within organizations pretty early on in his work. Now, there's various different examples from my own work of implementing sociometry, psychodrama, role-playing sociodrama in various organizations that I've consulted with or provided training in. And I wanted to offer you just some of those examples, and these are some of which are things that you can bring back to your organizations. In terms of sociometry, one of the simple examples is using spectrograms related to self-care, burnout, and vicarious trauma or vicarious growth. So more recently, I've been being called and invited and hired to provide trainings on vicarious trauma and burnout quite frequently. It seems like it's really prevalent in our professional community lately and really needed. So there's a series of spectrograms I often use in some sort of variation of which involves first asking, how consistent are you in engaging in your own self-care? And I ask individuals to line up on a spectrum within the room. That wall representing one end of the spectrum, this wall representing the other end of the spectrum. So from 1 to 10, perhaps. How consistent are you in engaging in self-care? And we get everyone lined up on a spectrogram. And then we can promote sharing and discussion about the things we do well in terms of self-care and the things that are limiting us in terms of implementing more self-care. Then I might ask another spectrogram question. 1 to 10, how often do you feel burnout or secondary trauma or overwhelming stress related to the work that you do? And then we get everyone, again, on this spectrogram, reflecting on their experience and then discussing their experience with their peers, normalizing their experience, getting peer support with each other about it. And then I might end with the third prompt. Maybe, how much would you say the work has prompted you to grow as a person, as a professional? And everyone would line up again and reflect on their vicarious growth from their work. If you wanted to learn more about spectrograms, I encourage you to check out some of the other videos on this channel where I cover spectrograms in depth and even demonstrate them with a group. Another example of an experiential exercise in organizational setting is the use of circle of strengths exercise. This is where I would use props, usually a collection of fabrics and scarves, for the exercise, and the team, the professionals, would stand in a circle around the pile of scarves, and I would ask them to choose a scarf that could symbolize a strength that they see in the person to their right. And then I would facilitate a group process of individually presenting that strength to the person to your right, and the rest of the group bearing witness to that. And then we might go to the left the next time, and everyone would present another strength to somebody else. We could even be more specific and ask them to choose a strength that can help them manage burnout and grow from their work. This gives everyone an opportunity to see how others in their department or in their organization experience them, and it really becomes a heartwarming experience to receive a strength and hear how somebody sees you embody that strength, sees the positive qualities within yourself. It's often something that many people struggle to see within themselves is their goodness. This exercise can be modified in different ways. You could ask group members to choose a scarf to represent a strength within the entire group, within the organization, within the clients they work with, or the modalities they use. Regardless, this exercise ends up being a really vulnerable and uplifting process. It provides everyone with an avenue for practicing vulnerability with each other based on positive criteria and really honoring the contributions of each other on the team. Many times I'll demonstrate this in a treatment team and teach how they can use it with their clients, but I'll later get feedback from the leader of the organization that the experience of participating in that seemed to enhance the cohesion of the organization or the team or the department in a way that was really meaningful. And I've even gotten feedback from some clinical directors or executive directors that the cost of the training day was worth it just for that exercise and how meaningful it was for staff to participate in that together. If you wanted to learn more about that exercise, the Circle of Strengths, I encourage you to check out some of the other videos on this channel that demonstrate and provide a more comprehensive overview to facilitating this exercise. Another sociometry tool that I often use in organizations related to trauma-informed care is a floor check. And this is where I would take a topic that has subtopics, and I would print out those subtopics, those options, and I would put them throughout the floor, and I would ask a series of questions to the group, and with each question, invite them to come physically stand at the option, the piece of paper, that answers the question for them. So, for example, if I'm doing a consultation with an organization about trauma-informed care, I am likely to print out the 6 trauma-informed care principles and put them throughout the room, and then ask a series of questions. Which principle do you feel you most embody in your work as an individual? Which principle do you feel you have the most room to grow in your work? Which principle do you feel your organization has the most room to grow in? Which principle do you feel your organization is doing the best job of embodying already? Which principle do you feel you and your team have grown in the past year? There's a variety of questions you could ask. Each will result in new configuration of staff members standing at different principles in different clusters, and you can initiate some short sharing, either at the group level, let's hear why people chose the principle they chose, or in small groups, where you're promoting self-reflection and peer support and mutual aid within the organization. This also provides a group as a whole assessment for you and for the organization. With each question, you can take a step back and look at where did people choose to stand or not stand? Which of these principles does the staff think we're doing the best job with or the worst job with? And that can be really helpful for organizational assessments for trauma-informed care. So lots of different ways you can modify floor checks for use in trainings and therapy groups and community groups. If you wanted to learn more about that, I would encourage you to check out some of the other videos on this channel. There's another teaching video where we demonstrate the use of floor checks. I think the example we used was a feeling floor check, where we put different feelings out and had people stand at the feeling that answered the question for them. Which feeling do you experience today? Which feeling do you most try to avoid? Which feeling is hard for you to tolerate in somebody else? Which feeling have you gotten better at managing for yourself? And so on. So beyond sociometry, there's also different role-playing exercises that can be really useful in organizations. And I wanted to share just a couple examples from my own work of how I've implemented role-playing within different organizations. So one I sometimes call is supervision in action, where I'll come to an organization. Usually this is an organization that I'm providing ongoing consultation and training to, and I'll invite them to reflect on examples of difficult interactions with their clients or residents. And we'll collectively choose an example, and then we'll choose people to play the roles of the people in that example, and we'll role play it. So this was an exercise that a residential treatment organization that I've provided ongoing training to really appreciated. So we had done it a couple times there. One of the examples that came up was the struggle between staff and residents about getting residents out of bed on time and making their bed and getting ready for the day, and how it often turned into a power struggle between the staff member and the resident that didn't want to get out of bed. So we role played this by having staff member play the role of the resident and play the role of the staff member. And we reenacted it. And then we paused it, and I used the psychodrama intervention called doubling, where either myself or others in the group come and stand next to one of the roles and offer a statement that might express what's going on just beneath the surface for either individual in the interaction. A feeling, a thought, or something that labels the deeper experience that's being had. Something that's unspoken. Something that's unexpressed. And so we took turns and we came in, we doubled for the staff member. And they said things like, "I'm just so angry at having to do this as part of my job." Or, "So frustrating that this person never wants to get out of bed." Or, "I have so much things to do today. The last thing I need to do is to be here trying to get a grown man out of bed this morning." Or, "I'm feeling really ineffective in that I can't motivate this person to get out of bed." So we doubled for the staff member. Then we came and we doubled for the resident. What might the resident be feeling or thinking in this moment? And statements such as, "I feel hopeless," or I'm feeling really depressed," or "I'm not sure that I have any reason to get out of bed," or "I can't stand it when somebody's telling me when I have to get up," or even being in a recovery house or a treatment center and being yelled at to get out of bed reminds me of my abusive father yelling at me in my bedroom. These doubling statements really help humanize everyone involved and help deepen our understanding of what could be going on, some of the underlying processes, feelings that are impacting the behavior. After the doubling, then we go into what's called role training. And this is where I would invite the other participants to step into the role of the staff member and to practice rehearsing new responses to the resident who doesn't want to get out of bed. And everyone can even have a chance to step into the role of staff member for a minute, 30 seconds, and to demonstrate with their own style, with their own unique approach, how they might try to motivate that staff member to get out of bed. And then this provides the group with a really rich experiential learning process, in that if there's 10 or 20 people in the training, we get to see 10 or 20 different styles, different approaches for the same circumstances. And it gives everyone a chance to learn from each other. This is also an exercise that can be used for exploring transference and countertransference in relationships, in that we might reenact a difficult situation and then pause it, do the same doubling, and then reflect on if there's transference or countertransference going on. Who is it that the client is transferring onto the staff member, and who is it that the staff member is transferring onto the client? And we can even choose people to play those roles, and it can evolve into a deeper role play for the purposes of self-awareness, for trying to renegotiate projections and countertransference on the clients we're working with, and also for engaging in our own healing about the source of our projections or countertransference. Another place where I used this was in a supervision group in a treatment center. And the situation was about how to provide interventions for clients who don't want to be in treatment anymore and who have decided they want to end their treatment and leave residential treatment against medical advice. And so we had somebody role play as the client saying they want to leave treatment, and somebody role playing as the therapist or the professional trying to intervene and talk to this client, motivate them to stay. And so we used that same doubling and role training interventions, and it became a really rich experience. And again, we got to see 20 different therapists each take a moment and step into the role of therapist and demonstrate with their own style, with their own theoretical backgrounds, with their own personality, how they might motivate somebody to try to stay in treatment. That experience was so rich, I still talk about it. It was probably 7-8 years ago, and I still think about it at times. So lots of different ways we can use role-playing within organizations to help troubleshoot different situations. I even use smaller role plays to help staff members practice difficult conversations with their clients or customers, or help supervisors practice difficult conversations with their supervisees, or to help leaders practice difficult conversations. Another psychodramatic process that I often use is a multiple empty chair process. And this can be modified for different circumstances, different themes. On the theme of burnout and vicarious trauma, I might pull out 2 empty chairs, one to represent the therapist or professional, the other to represent the client. And I'll provide a little bit of context. I might start by saying, in this first scenario, the professional, the therapist, is really struggling with burnout and vicarious trauma while trying to provide services to this client. Then I'll invite participants to come and sit in either one of the chairs for just a moment, one at a time, and to offer a statement, almost like a doubling statement, about what either party might be thinking or feeling. So somebody might come and sit in the chair of the therapist and say, "Man, I'm just exhausted. I don't know how I'm possibly going to be able to help the person in front of me." Or someone might come sit in the chair of the client and say, "Man, this therapist is boring, is not very engaging, and just seems distracted. I don't think they can really help me." And so on. And we might have 5 or 10 different people come and sit in each chair and offer one statement, just articulating what could be going on for either one of these roles. And then I'll switch it and say, now this is a therapist who's engaged in their own self-care and supervision and training and is well-balanced and fully present for the client. And now let's do the same process, but with this new scenario. And you end up with very different statements that are being said from each of the roles. So this is a simple, sometimes fun and funny exercise using sociodrama rather than psychodrama, because it's not somebody's actual specific story. It's just a collective story with collective roles. And it's an exercise that allows us to interface with and engage with the roles of client and therapist and the phenomenon of burnout. It can really help us normalize our experiences and be more aware of our experiences and how it impacts the client. Similarly, I've used this exercise when teaching about trauma-informed care by putting out 3 chairs, one for the client, one for the staff, and one for the leadership. And I do a similar process of asking individuals to come and make a statement from any of the roles, just one statement, and then they sit down related to different circumstances. I might say, in an organization that's not so trauma-informed, what are the things that each of these roles might be thinking or feeling or doing? And people might come and step into them and make different statements. And then I switch it at some point and end with the positive. In an organization where the staff and the leadership are implementing trauma-informed care, what might the client, staff, and leadership be feeling, thinking, and doing. And again, people would come, step into the chair for a moment, make a statement, and then go sit down. So this can be really a cathartic experience and a fun experience, and also a really meaningful learning experience about how the presence or lack of presence of trauma-informed care can really impact staff, clients, and leaders. Now, if I were to use psychodrama in its more complete form in an organization, I can certainly do full psychodramas in training groups or organizational groups to work through stressors or conflict or other issues to support the staff in their own personal and professional growth. For example, I often will do strength-based psychodramas in organizational training groups on psychodrama related to overcoming professional barriers or issues. So if a therapist is struggling with confidence in their work, we might do a psychodrama with them and give them the opportunity to connect with different strengths and different roles or mentors or even a higher power that can help them with a sense of confidence. And they'll have the opportunity to talk to these different roles and to reverse roles and become their courage, to become their mentor, to become their higher power, and speak to themselves from those roles about confidence in their work. So this can be really therapeutic and provide an avenue for engaging in personal and professional growth within a training setting. I've also used it for staff members when they're struggling with conflict with a colleague or with a supervisor or with a client. We can have them enact that conflict in the psychodrama and then explore ways of resolving that conflict. I've even used psychodrama for myself related to workplace issues, about having a psychodrama with a leader of an organization, trying to advocate for change within the organization, or practicing negotiating for a salary increase or a new contract to teach at an organization. I might do a short psychodrama and reverse roles with the leader and consider what the leader might need to hear in order to hire me or to increase a salary. So psychodrama can be used for lots of different things in organizations. Another memorable experience was I had a staff member that was struggling to pass their license exam for their license to practice. And they had failed it and they were really anxious about it. And so we did a psychodrama where they had a conversation with the licensing exam. And they spoke to it and they looked at their relationship to the licensing exam. And they reversed roles with it and spoke to themselves about what their purpose was and how they could have a better relationship with this license exam that they needed to pass. This was a very fun and even a humorous, very funny psychodrama at times, but also really meaningful in that many people could relate to the anxiety of test taking, but it really humanized the test and gave individuals the opportunity to interact with it and change their relationship with it, to befriend it rather than to be afraid of it. And interestingly, maybe coincidentally or not, the therapist who was the protagonist of that psychodrama emailed me a couple months later and said they passed their license exam on their next attempt after that psychodrama. So lots of creative ways we can use psychodrama within an organization. So again, psychodrama, sociometry, experiential teaching can be used in organizations, not just to provide training on trauma or psychodrama, but also as a teaching method for providing training on trauma-informed care, for helping staff members address burnout and vicarious trauma, and promoting vicarious post-traumatic growth. Really, any topic, any content can be put into sociometry and psychodrama structures, role-playing structures, so that the sociometry and role-playing becomes the experiential teaching method that's being used to teach any particular content. So it's really versatile. Providing sociometry, psychodrama training at your organization, however, offers engaging avenues to engage in peer support, in self-care, and in learning while providing new skills to your staff. So there's lots of good reasons to consider bringing psychodrama training to your organization. And if you wanted to learn more about that, I encourage you to reach out to me. I often provide training at different treatment centers, universities, community groups, conferences, international settings, and would really invite an opportunity for a discussion to talk about how psychodrama or trauma-informed care, or even workshops on vicarious trauma and burnout and vicarious post-traumatic growth could benefit you and your organization. So if you found this video useful, I encourage you to subscribe to our channel to receive updates about future videos. Leave a comment below and tell us what specifically you found most interesting or most helpful. And look forward to hearing from you.